Welcome, I'm Erik van Cutsem, and I will give you a short overview on the data of the MAESTRO Phase III study of Evofosfamide in combination with gemcitabine versus gemcitabine alone in patients with pancreatic adenocarcinoma. Indeed, we know that the tumor microenvironment in pancreatic cancer is characterized by hypoxia. And Evofosfamide is a hypoxia-activated prodrug that preferentially releases an important metabolite in areas of severe hypoxia. And we know that combining Evofosfamide with conventional chemotherapy has the potential to induce cell death in hypoxic and normoxic tumor cells. And as we saw in a Phase II study that was published in the Journal of Clinical Oncology in 2015, the combination of gemcitabine plus Evofosfamide was more active compared to gemcitabine alone. Progression-free survival, which was the primary endpoint, was indeed longer. And based on this initial Phase I and then later Phase II study, the regimen was selected. And therefore we designed this Phase III study, which we called the MAESTRO study. This was a study in locally advanced or metastatic pancreatic adenocarcinoma. Patients were randomized between gemcitabine plus placebo or gemcitabine plus Evofosfamide. And almost 700 patients were included in this trial. The key eligibility criteria were straightforward: histologically proven pancreatic adenocarcinoma, a good performance status, good liver, renal, and hematologic function, and no prior chemotherapy for metastatic disease. And patients suitable for FOLFIRINOX were also ineligible unless the patient refused FOLFIRINOX. Primary endpoint in the study was the overall survival, and a report also on some of the relevant secondary endpoints. We calculated that a sample size of more than 660 patients was needed for the survival as primary endpoint in order to detect a hazard rate of 0.75 for overall survival, which means that there was a survival benefit, a median survival difference going up from 6.5 months to 8.67 months. There were no differences in baseline characteristics and patient demographics between the two arms. Patients came from different regions, including Europe, US, and Asia. 1/3 of the patients had an ECOG performance status 0, 2/3 an ECOG performance status 1, and around 20% of patients had locally advanced disease and almost 80% of patients metastatic disease. The primary reason for treatment discontinuation was tumor progression, and this was more frequent in the patients treated with gemcitabine placebo compared to patients treated with gemcitabine Evofosfamide. Looking at the adverse events, there was especially a difference in hematologic adverse events. There were more patients with neutropenia, thrombocytopenia, and anemia in the arm of gemcitabine plus Evofosfamide compared to gemcitabine plus placebo. However, this increased incidence of neutropenia did not lead to an important difference in febrile neutropenia. Looking at some of the non-hematologic adverse events, there was no important difference between the two groups of patients, but again a slight difference in diarrhea, which was slightly more frequent in patients treated with a combination of gemcitabine Evofosfamide. Looking at the primary endpoint, which was survival, there was a trend towards a longer survival, but no statistically significant difference. The study was therefore negative. The hazard ratio was 0.84 with a log-rank p-value of 0.059. And the median overall survival was 7.6 months in the control arm and 8.7 months in the combination arm. And this median survival in the combination arm was as we expected. However, the median survival, as well as the 1-year survival in the gemcitabine placebo arm, was longer than expected. We don't have an excellent explanation for that, but we can see that there were slightly more patients treated with subsequent therapy when they were allocated to the group of gemcitabine placebo compared to patients treated with gemcitabine Evofosfamide within the trial. Indeed, if you look at the numbers of subsequent therapy with FOLFIRINOX, FOLFOX, or gemcitabine nab-paclitaxel, this was slightly higher in the placebo arm. The progression-free survival was longer for the combination arm with a hazard ratio of 0.75, and this difference was statistically significant. Median progression-free survival went up from 3.7 to 5.5 months. And also looking at the objective response, the confirmed response rate went up from almost 10% to 16%, and also more patients had a drop in CA99 level when treated with a combination of gemcitabine Evofosfamide compared to gemcitabine placebo. So in conclusions, we can say that this Phase III MAESTRO trial did not meet its primary endpoint of showing an overall survival benefit of the combination gemcitabine plus Evofosfamide compared to gemcitabine alone in patients with pancreatic ductal adenocarcinoma. P-value was 0.059. There were, however, clearly signs of overall anti-tumor activity for the combination arm, looking as well at the overall survival, progression-free survival, response rate, and CA99. There were slightly more hematologic adverse events for the combination arm, and it's clear that further analysis should be done. Thank you for your attention.